I'm Christine Buckley with the Brain Aneurysm Foundation, and I welcome everybody to our monthly webinar series. We took a break in July, so happy to be back now. And we are really fortunate to have with us Dr. Cooper, who's at White Plains Hospital with the Department of Neurosurgery and Neuroendovascular Surgery. And I'm sure most of you saw, he's going to be talking about a family's guide to navigating acute aneurysmal subarachnoid hemorrhage, which I think is really an important topic, probably close to all of you, but I think he's really going to give us a great presentation, touch on a lot. So for now, I'd like to pass things off to Dr. Cooper. Again, thank you for giving your time and sharing your expertise with us.
Oh yeah, thank you, Christine, and thank you to the Brain Aneurysm Foundation for having me. I mean, this has been months in planning, and I'm really excited about this. And thank you to everybody who's joining. You know, I hope you find this helpful. Like Christine said, my name's Jared Cooper. I'm a neurosurgeon at White Plains. My general practice is neurosurgery, but I'm a subspecialist in endovascular neurosurgery. And in particular, my interest is in cerebral aneurysms, particularly in the brain, but I treat vascular pathology kind of all over the body, primarily in the brain and spine. And really, you know, my thought is if you're here, it's probably because you already know or had an experience with a patient who's had an aneurysm. Perhaps a caregiver or a family member trying to learn more about what happened to a loved one. But either way, you know, when we were preparing this talk and coming up with this idea, I felt like it would be important to go over kind of the real life course of a patient with aneurysmal subarachnoid hemorrhage to try to demystify some of the questions and concerns and unique aspects of the pathology. One of the things that I noticed, and I expressed this to Christine, is that as a resident and a fellow, when these patients would come to the hospital, we would meet with the patient's family who was already in somewhat of a shock about what was going on. And we would try to summarize this condition that will forever change their lives, along with this 3-week-long marathon of a hospital stay that they have in front of them. And because of the urgency to get the aneurysm treated, the patient would often then be whisked away for treatment. And people, I would feel, were confused and kind of needing more, and there was a lot of uncertainty. So my plan today is really just to review the hospital course of a patient suffering from aneurysmal subarachnoid hemorrhage, detailing the first few hours through their critical care course and discharge. And then afterwards, you know, I'd love for some feedback from the group and questions, and particularly I'd like to learn as a practitioner how we can do better with the way that we speak to you guys as family and friends and caregivers when somebody arrives with subarachnoid hemorrhage, and you know how we can improve that process. So let me share my screen real quick. All right, so as a brief overview, we'll be discussing, like I said, the background pathophysiology of cerebral aneurysms, initial presentation, treatment, the critical care management in the first days and weeks following the treatment of the aneurysm. And then ultimately, we can discuss discharge and rehabilitation. And so let's start simple by describing what an aneurysm is. And effectively, an aneurysm is just the dilatation of the wall of a blood vessel. And it commonly occurs at branch points, and they can be congenital, they can be flow related, they can be due to trauma or infection. And I have a little diagram down here. You can see this is kind of the normal course of a blood vessel with a branch vessel coming off here. And here you have this abnormal dilatation or ballooning or outpouching of the blood vessel, and that is the aneurysm. This is referred to as the dome of the aneurysm. This is the body, and then this is the neck of the aneurysm. And there's a bunch of different conformations or morphologies of the aneurysms. This one is, the second one here is like your typical berry aneurysm. This third picture shows what's called a wide-necked aneurysm. And then the last one is a fusiform aneurysm, which rather than having kind of this berry-like outpouching, has this circumferential dilatation of the blood vessel. So where are aneurysms found? Typically at branch points of larger blood vessels, but they can also be seen at the origin of smaller perforating vessels that are not always as readily visualized on standard imaging. And so in order to understand this, we should take a look at this diagram here, referred to as the circle of Willis. So the circle of Willis is, as cerebrovascular surgeons, kind of like the key to everything for us. There are 4 blood vessels that supply the brain: the internal carotid arteries, which you can feel in your neck, and then there's 2 vertebral arteries, which course up along the spine, all of these coming from the heart. And at the base of the brain, they form a circle by all these different anastomotic or connecting blood vessels. And aneurysms tend to occur, cerebral aneurysms tend to occur along the intracranial portions of this circle of Willis. There's the anterior cerebral arteries here, the middle cerebral arteries here and here, the posterior communicating arteries, and then the posterior circulation, which is comprised of the basilar artery, posterior cerebral, superior cerebellar, anterior inferior cerebellar, and posterior inferior cerebellar arteries. Most aneurysms occur in the anterior circulation, which is this segment up here, the internal carotid, middle cerebral artery, and anterior cerebral arteries. That's like 90% of aneurysms, with a majority of those occurring at this, what's called ACOM, or anterior communicating artery complex, right here. The remainder of the last 10% occur in the posterior circulation, which is back here, kind of along the brainstem. And then subarachnoid hemorrhage essentially is extravasation of blood from one of these blood vessels into the subarachnoid space, which is the space wherein which these blood vessels all live. Most of these subarachnoid hemorrhages come from ruptured aneurysms, or at least a non-traumatic subarachnoid hemorrhage mostly comes from aneurysm rupture. There are other different things that can cause subarachnoid hemorrhage, like arterial dissection, AV fistula rupture, spinal cord vascular lesions, pituitary apoplexy, and something called RCVS. But for the purposes of today's conversation, we're really just going to be talking about aneurysm rupture. And in this picture, you can see the kind of classic pattern or starburst pattern of blood. The gray tissue here is normal brain. This black here are the fluid-filled spaces of the brain called ventricles. And then this bright kind of star pattern is blood in the subarachnoid space. So the incidence of aneurysm rupture causing subarachnoid hemorrhage, about 10 in 100,000 worldwide, but affects up to 30,000 people annually in the United States. The incidence increases with age, occurring mostly in the ages of like 40 to 60 years old, with a mean age of around 50 to 55 years. And mortality rates can be pretty high, up to 45%, with significant morbidity among survivors. Like I said, the mean age is about 55. It's 1.6 times more common in women, and just over 2 times more common in African-American population. 15 to 30% of these patients that have aneurysm rupture are found to have multiple aneurysms. And the risk factors for subarachnoid hemorrhage include hypertension, smoking, female gender, tobacco, and heavy alcohol use. And there's a family tendency that's well recognized as well. And it's something that we definitely influence or try to emphasize with our patients, which is that if you have more than one family member who's had an aneurysm or aneurysm rupture, that screening imaging can be very helpful at detecting these things early, so that you can prevent any further devastation. And so really there have been a lot of attempts to determine what contributes to rupture, but ultimately it's believed to be related to aneurysm size, location, morphology, or the shape of the aneurysm, and then these patient risk factors that we just mentioned. So the natural history of untreated rupture aneurysm is actually quite alarming, with about 10 to 15% dying before they even reach the ER. 25% dying within the first 24 hours, and a 50% overall mortality. So these kind of staggering numbers really illustrate the importance of promptly identifying and treating an aneurysm rupture. And so when a patient suffers from a ruptured aneurysm, the most frequent complaint, the most common complaint, is the worst headache of my life. So when we hear that as neurosurgeons or in the ER, all of our ears perk up, and it's the first thing that we often think about, or it's the first thing at least that we should be thinking about. It's often characterized as a thunderclap headache. and it's likened to being struck by lightning. It's really unique in comparison to what you would consider a typical headache. It's often combined with neck pain, light sensitivity, blurred vision, altered consciousness, focal weakness, or seizures. I bring up this concept of a sentinel headache that's described in about 20% of patients. This is really tough to pick up on. It can essentially be a warning headache. It's often not as severe as the aneurysmal headache, but it is typically described as different than any previously experienced headache. And this is thought to come from like tiny leaks or microbleeds from the aneurysm, and they could be alluding to the fact that the aneurysm is unstable and more likely to rupture. So if you're fortunate enough to pick up on something like this, it could be a dramatic help to your clinical course in being able to treat the aneurysm earlier. Importantly, subarachnoid hemorrhage misdiagnosis used to be huge, something in like the 40s, 40 percentile kind of territory, but it's now down to 12%, but still that 12% is a big number. Misdiagnosing this can really lead to issues that can be catastrophic. So understanding the headache characterization, recognizing that this is different than usual headaches, and prompting having that prompt imaging is really critical in identifying a bleed. So a typical first place to start with imaging is non-contrast head CT, which you can see in this kind of top image here. And this is really what it looks like. See that again, this bright kind of starburst pattern of blood is the subarachnoid hemorrhage. CT has a really excellent early sensitivity for detecting bleeds, which slowly tapers as time goes on. And so if the patient arrives several days later, an MRI might actually be beneficial in detecting blood products a little better than a CAT scan. A CT angiogram is often performed in order to study the blood vessels. It's essentially a CT with contrast dye. And in most cases, an aneurysm can be identified by this modality. However, in some cases, there is no vascular lesion identified. And that's a whole separate pathology that we can talk about maybe another time. But if a patient is found to have an aneurysm on CTA, but there's no evidence of hemorrhage on the non-contrast head CT or an MRI, but you're worried because somebody came in with a really severe headache, that's where you find yourself in the territory where you're thinking about maybe doing a lumbar puncture or a spinal tap. And so I have a diagram of what this looks like over here. And essentially, the subarachnoid space in the brain is communicating with the space in the spine that harbors the cerebrospinal fluid that surrounds all the nerve roots in the spine. So you can introduce a needle to that space in the lumbar spine or the low back, and you can test that fluid for blood products. You can see here, this is what normal cerebrospinal fluid should look like. And this is called xanthochromic cerebrospinal fluid or blood-tinged cerebrospinal fluid. And that can be suggestive of a subarachnoid hemorrhage. But ultimately, at the end of the day, if you're concerned about a patient having an aneurysm, you found one on CT angiography, you're concerned that there's bleeding, cerebral angiography or catheter angiography is the gold standard. And there's two grading scales for evaluating subarachnoid hemorrhage. The first one is the Hunt and Hess scale. And this essentially grades patients based on the severity of their presentation clinically. And the higher the clinical grade, the higher likelihood of mortality, which you can see in the percentages represented here. This scale is like 70 years old and has been kind of updated in some forms or fashions to be a little bit more precise with respect to like the actual mortality outcome, but this is still widely used as the most common grading scale for patients who arrive with subarachnoid hemorrhage. The next one is the Fisher scale. And this is an evaluation of the degree of hemorrhage that's found on that initial head CT and relates it to the likelihood of developing vasospasm and delayed cerebral ischemia, which are concepts that we'll discuss just in a little bit. But you can see that they're essentially related to the thickness of the subarachnoid hemorrhage and the amount of intraventricular blood, which is blood in the fluid-filled spaces of the brain called ventricles. Like I said earlier, and I'll continue this kind of concept throughout my talk, aneurysm rupture survival is really a marathon, and the first 24 hours can be a total whirlwind for the patients, their families, or caregivers. And so I felt it's important, to understand the different phases of the hospital stay. So I kind of summarized them here. There's a bunch of different iterations of this concept, but this is the one that I found, to be the best interpretation. So the first phase is this immediate life-saving care portion of their presentation, followed by aneurysm treatment, and then the critical ICU period, which can last up to 2 weeks or even longer after they arrive. Preparing for discharge. So this is when you've been stepped down or downgraded from the ICU and you're trying to work your way towards rehabilitation. And then there's the discharge and rehabilitation phase. Another equally important factor in understanding your hospital stay is understanding your treatment team. I found that for families, it's really good to have a point person because it can be completely dizzying to meet these new faces every day, especially with each of them giving you their own viewpoint and opinion about the treatment plan and what needs to be done next. And it creates a lot of confusion. So I'll go over who you're going to meet and then how the kind of care team is structured. So everything starts in the ER with the ED attending and the nurse. Those are really the first people that you're going to meet when you get to the hospital who are going to guide those initial phases of evaluating the patient and getting imaging. But then quickly after that, you'll likely meet the neurosurgeon and neurointerventionalist, who for all intents and purposes will be the captain of the ship in your hospital stay. And if you ever need to go back to somebody to find kind of a point of reference for how things are going, it's typically these people. It's going to be the neurosurgeon, the neurointerventionalist, and then the neurosurgery residents, fellows, and APPs are essentially the eyes and ears for that person or those people who will be involved in delivering the day-to-day information, updates. They'll be the ones who likely obtain consent for procedures, et cetera. Then you have the neurology attending in residence, as well as the neurointensivist and their team, which includes an ICU resident and APP. And these people are really going to be the ones who are discussing the comprehensive medical care of the patient. And they're the ones that are going to round in the ICU and give updates on really the system-wide care of an aneurysm rupture patient. Of course, the nurses and nurses' aides are really going to be your point person for the daily or even hourly updates. They're at bedside and become most familiar with the patient and their day-to-day activity and progress. And so they'll essentially become a part of your family because they'll provide this incomparable support for your loved one. And they're really going to get to know you and your family and the subtleties of the patient's exam and the things that you want to hear. They're going to be able to kind of provide you a real-time update on a lot of that information. And so as you progress through the hospital stay, they're really going to be elemental in giving you these kind of minute-by-minute updates. And then as you move further into your hospital stay, you're going to end up meeting the physical, occupational, and speech therapists, as well as the social workers and case managers who will help you navigate through the care needs of your loved one and help plan for their ultimate disposition. So I know this is one of the kind of the hot topics for this conversation. One of the earliest decisions you're going to end up making is establishing a healthcare decision maker. There's a hierarchy of surrogacy, which I have depicted here in this kind of ladder. That first begins with the healthcare proxy or guardian, then followed by a durable power of attorney, the patient's spouse, adult children of the patient, parents of the patient, adult siblings, other adult relatives, and close friends. Most people in the healthcare field will kind of have some degree of understanding of this ladder and will help guide you as a family into kind of electing somebody who's going to be the decision maker. The hardest period for this is always the first hours of somebody arriving to the hospital, because it's everybody has lives and people could be inaccessible at a given time, and somebody who's not high up on this list might be left with the difficult decision making task. But ultimately, this is something that we fall back on as patients' families become more readily available. And a really important thing that I like to remind my patients' families is that, if possible, no decision should be made alone. That can be a very lonely feeling, a very scary feeling. Each decision carries a lot of weight and can be really life-changing for the patient and your family. And ultimately, one thing you need to keep in mind at the forefront of your attention is what the patient would want if they could speak for themselves. This is often the hardest thing to be consistent with because it requires a degree of selflessness that sometimes can be a challenge to your own beliefs or your own values or what you would want for yourself, but you're really trying to put yourself in the patient's shoes and understand what they would want for themselves in this situation and use that to help support your decision making. But that's really where other family members, loved ones, friends can help, because they can help you establish a balance in the decisions that you're making for this family member. And so that's really important, so that you don't feel alone or feel the stress of having to make these kind of burdensome decisions on your own. So from here, the patient will undergo the initial stabilization measures, which include the ABCs, or airway, breathing, and circulation, which are kind of like the emergency triage steps in a patient, followed by blood pressure control, coagulopathy reversal. So if they're taking like an anticoagulant medication for something like atrial fibrillation, you reverse that so that it doesn't contribute to worsening of the bleed. Seizure management, hydrocephalus or ICP control, and then aneurysm treatment. And so I'll get into kind of some of these steps here. So like I said, the first thing is management of first procedural thing is really management of hydrocephalus or increased intracranial pressure, and that is accomplished using something called an external ventricular drain. I imagine that if some of you are family members of an aneurysm rupture survivor, that many of you are familiar with what this is. And essentially the concept here is that when somebody has a subarachnoid hemorrhage, the blood products can cause an obstruction of the natural fluid-filled pathways of the brain. And the way that I describe this to patients' families is that you can liken this to a clogged sink with the faucet still running. Because our skulls are fixed boxes, the fluid spaces that I had pointed out earlier can increase in size, causing an elevation of pressure in the head, which can ultimately cause irreversible brain injury. And so the EVD is a catheter that we can introduce into the fluid-filled spaces of the brain, or ventricles, through a small hole the size of a pencil eraser, in order to drain off some of that fluid, but also measure the pressure in the head. And really, I can't understate how important something like this is, especially doing it early and promptly. This could really save somebody's life, because once you reach a critical point in elevated intracranial pressure, you become the subject of irreversible brain injury. So this can really save lives. And then the next step is assessing whether or not to clip or coil the aneurysm. And this is a topic of constant conversation and can be looked at from a number of different vantage points. And so I'm not going to get into all of the details, because that would be like a several-hour discussion with a lot of back and forth. But we will review some of the basic concepts here, the benefits and limitations of each of these, and kind of the basic literature that's contributed to the development of the techniques. So the first thing that we'll talk about is microsurgical clipping, as this is really the historic treatment method used for ligation of aneurysms. It's widely considered the most durable treatment strategy by eliminating the aneurysm by placing a surgical clip across the neck of the aneurysm. You can see different examples of that here in these illustrations. In certain cases, people even clip the aneurysm and then deconstruct the aneurysm dome. So it's truly eliminated. And in effect, that's why this is the most durable solution, because the aneurysm is essentially completely excluded from the circulation altogether. And so therefore, the recurrence and need for retreatment is pretty uncommon with clip ligation of aneurysms. That being said, there's limitations with this technique, of course. It's invasive, so it requires an open craniotomy to do this. And it oftentimes requires brain retraction. There can be difficulty in accessing certain lesions depending on the location of the aneurysm. And, perforating vessels and cranial nerves are also subject to injury depending on their location in relation to the aneurysm. So the invasive nature really is the crux of the limitations for for microsurgical clipping. That being said, there's a lot of minimally invasive techniques that have been developed over the last 10 to 15 years that have really improved this, including the keyhole craniotomy and retractorless surgery. And so, as with anything, our techniques have gotten better over the years. And so, to keep things moving, we'll discuss coiling next, and you can see some examples of coiling here in the slides. This technique was popularized in the early 1990s, and its benefit was really touted as being less invasive with a more rapid recovery and an excellent safety profile with satisfactory efficacy. And so this is limited in that it's less durable than clipping, and that the aneurysm is not completely excluded from the circulation. And there are certain nuanced, challenges in treating aneurysms based on their morphology. So if they're wide-necked or they're giant or they have vessels that are incorporated into the body or the neck of the aneurysm, that's really where certain limitations come for aneurysm treatment by endovascular techniques. But as you'll see, there's been a number of ways that that's been overcome as well. So just to go into some quick trial data, not to bore you with literature, but the major trial that opened the door for endovascular treatment is something called the ISAT trial, or the International Subarachnoid Aneurysm trial, which was an international randomized prospective trial of over 2,000 patients with ruptured aneurysms that were amenable to either clipping or coiling. And so they found initially that coiling was more likely to result in independent survival at 1 year than microsurgical clipping. And they found as well that the risk of late rebleeding was low, but it was more common in the coiling group than the clipping group, for the reasons that I stated before about clipping being kind of a more durable solution. In their long-term analysis, they found that more of the coiled patients achieved functional independence at long-term follow-up than the clip patients. And they found that there was a slightly increased rate of death and dependency amongst the microsurgical clipping group, probably because of its invasive nature. But that being said, the rebleeding was again more likely to happen in the coiling group than the clipping group, though it was a small percentage of patients that required retreatment, but for rebleeds, but it was still more likely to happen in the coiling group. So you can see here that as a result of this publication, this is kind of why I went into it, the amount of patients that underwent endovascular treatment for aneurysms like skyrocketed, and this happened in the early 2000s and kind of has persisted today. Just to kind of balance that out, the other major study that was published around the same time was the barrow rupture aneurysm trial, which randomized patients into treatment either with clipping or coiling, but without this pre-screening that happened in the prior trial. So rather than saying, okay, this aneurysm is amenable to both, we'll send it to clipping or coiling, this one just took any patient with a ruptured aneurysm and sent them like AB, AB, AB style. And so as you can imagine, some aneurysms just are more amenable to clipping than coiling. And there was a lot of crossover because of that. That being said, ultimately what they found was that there was a lower percentage of patients that were dead or dependent in the coiling group relative to the clipping group, so similar to the ISAT trial. But as their follow-up continued over 3 to 10 years, this began to normalize and was no longer significant. They had similar long-term outcomes. And they also found, similar to the ISAT trial, that the coiling group had a greater rate of retreatment. And like I said, ultimately, as techniques were refined for both coiling and clipping, the safety and outcomes of both techniques have actually greatly improved, and this discussion has become way more nuanced. So ultimately, how do we make this decision about clipping or coiling? And it's really a patient-specific question with treatments tailored to the specific needs of the patient, with a focus on assessing treatment risk, perceived outcomes. It has to do with the expertise of the person who's treating you. And so, it's a more nuanced decision than just, this one is better than the other one. And the patient selection is based on things like age, clinical condition, comorbid conditions, life expectancy, different aspects of the aneurysm size, morphology, dome to neck ratio, whether or not there's calcifications, thrombus in the aneurysm, branch vessels, whether or not there's a large blood clot that requires surgery to evacuate, and then also patient and family preference. you know, like I had alluded to earlier, the family is just as involved in the decision making as the practitioner. Obviously, it's our job to help educate and guide you through the decision making process, but it's your or your loved one's body. So, it's a collaborative decision. Just to touch on this briefly, because of all of this, and because endovascular treatment became such a popularized way to take care of aneurysms, especially those that have ruptured, there have been a number of different techniques that have come out since the invention of coiling, like stent-assisted coiling, balloon-assisted coiling, intrasaccular devices like the web, flow diverters, which are stents that redirect blood flow, and a number of other pieces of technology that have really made it so that you can primarily take an endovascular approach at treating aneurysms up front, unless there's something that really would sway you towards doing open surgery. And like I said, there are reasons for that, but I'd say that most institutions offer an endovascular first approach, and then microsurgical clipping becomes a secondary option as needed. So now that your aneurysm's treated, what do the next few days look like? This is kind of what the acute care period looks like. You can see an average ICU bed in the neurocritical care unit. There's a picture that I actually stole from another Brain Aneurysm Foundation talk from MUSC, because it's just such a great picture and really captures the environment well. There's all these pumps and tubes and catheters and alarms, and there's frequent exams, and that can be really unsettling for patients' families to see and hear, and sometimes it might not appear so comfortable for the patient, but these are really all things that we're doing to keep this closely monitored eye on the patient, because there's so much for us to worry about, right? I also included pictures here in the bottom right, like this person performing a transcranial Doppler and CT scan, because these are things that happen on a routine basis in the first few weeks after an aneurysm rupture, to avoid things like vasospasm or hydrocephalus. And really all of this kind of comprehensively helps us manage in that acute period after a rupture. And so, like I said, there's a number of these different complicating factors that can accompany the hospital course. It's a very long list, so don't get alarmed by it, but effectively it can be aneurysm re-rupture, cerebral edema, hydrocephalus, vasospasm, cerebral salt wasting, seizures, myocardial stun, respiratory failure, neurogenic pulmonary edema, and central fevers, just to list a handful. And so a few of these I'm just going to go into some detail about, that are more common and things that we see regularly that are helpful to have an understanding of. The first one is the risk of rebleed, and rebleeding really is the most feared complication of a ruptured aneurysm, and it's the reason why upfront aneurysmal protection is so important. The risk of rebleed is 3 to 4% in the first 72 hours, then 1 to 2% each day for the first month cumulatively. So about 20 to 30% in the first month, and 50% within the first 6 months to a year. And the mortality with rebleed is much higher, so about 50 to 70%. 50% will die from the re-rupture, 30% will die from the medical complications associated with a rebleed, and of the survivors, about 20% are left dependent. So this really highlights the importance of recognizing an aneurysm rupture and treating it promptly. The risk factors for rebleeding are hypertension, low GCS or Glasgow Coma Scale, which is your exam, and delayed securing of the aneurysm. So to minimize the risk, of course, is to treat the aneurysm early or in a timely fashion, maintaining tight blood pressure control, and in certain circumstances, considering antifibrinolytic therapy, which is essentially like prothrombotic therapy to help prevent rebleeding. So something that we should discuss is vasospasm. So this really is important because it comprises so much of your hospital stay. It's really the reason why you have this marathon of a hospital, 21-day hospital stay. So it's one of the most common issues that we deal with in cerebral aneurysm rupture. And it starts typically in the window for vasospasm typically starts in the day 3 to 5 territory, and then peaks at the days 5 through 14, typically with complete resolution in days 14 to 21 extending sometimes to 28. But this is really where that 21-day hospitalization number comes from. Up to 30 to 70% of patients who have an aneurysm rupture will have angiographic or radiographic evidence of vasospasm, but only about 50% of those patients will be symptomatic. And this is one of those things that we spend a lot of effort screening for with the transcranial Dopplers or CAT scans to try to stay on top of, because these things can get away from you very quickly and they can be challenging to treat. And once they cause strokes, that could potentially become irreversible. And that's why this accounts for up to 50% of the mortality associated with patients who have a ruptured aneurysm. And so I included this great video from the Barrow Neurological Institute that really well demonstrates what happens. So effectively, the reason we have vasospasm is because when an aneurysm ruptures, blood leaks out into this subarachnoid space, which is where all of the blood vessels live. And over the course of, the first 21 days, that blood, as it's resolving, irritates the blood vessels around it, and they cause them to kind of clamp down. And as the blood vessels clamp down, it restricts blood flow to other important areas of the brain, and that can cause strokes. So the treatment of vasospasm is pretty complicated. So I'm not going to go into too much detail, but just some of the basics. It starts with things like permissive hypertension, maintenance of euvolemia or normal blood volume, augmenting cardiac output with medications, and then can become more advanced to include endovascular, like intraarterial medication therapy or balloon angioplasty, and then more significant measures like intravenous milrinone, intrathecal vasodilators through a ventricular drain, hypertonics, hypothermia, or intra-aortic balloon pump. Shifting gears to seizures, approximately 8 to 15% of patients with aneurysm rupture present with seizures, and sometimes assessment of that can be really challenging if a patient has a poor neurologic exam and something you can't follow. Typically, we'll put patients on anti-seizure medication for about 7 days. And then in a high-risk population, so those with a poor neurologic exam, ruptured MCA aneurysms, hydrocephalus, big clot, or a cortical infarct, will potentially have them on anti-epileptic therapy longer. And you might see this machine in the room, which is a video EEG monitor. And this accompanies the leads that we attach to the patient's head to monitor for seizure activity. And then lastly, in terms of like the complication management, we'll talk about hydrocephalus. So we already spoke about EVD placement, but once the EVD is in, how do we get it out, or how do we manage that? So there's typically a protocol for weaning the EVD that us as practitioners are pretty familiar with. Each institution does things a little bit differently, but effectively it has to do with gradual raising of the level of the EVD, and then eventually clamping it, making assessments along the way of intracranial pressure, exam stability, stability of the ventricular size. And if the patient can tolerate a clamping trial for 24 or 48 hours, you can remove the EVD safely. But if they're unable to tolerate that, then they might require something called a ventriculoperitoneal shunt, which I have here, which is essentially a more permanent solution to the EVD, where a catheter is tunneled under the skin to allow drainage of that excess fluid that is not being reabsorbed into the peritoneum, where it can be reabsorbed by the body. So at this point, you've made it through the critical period of an aneurysmal subarachnoid hemorrhage. So what comes next? You'll remember that I referred to this as a marathon. And so while a lot of the scary things are behind you at this point, there's still a lot of work that needs to be done. And, the recovery from a brain aneurysm is this major life event, and it can continue long after discharge. Survivors face physical, emotional, cognitive changes that can be minor, but they can also be really significant, and they can be subtle when somebody's in the hospital, but can be more pronounced when they're either in rehab or at home with their families. Ultimately, there's really no way to predict how long the road to recovery will be, but things like physical, occupational, and speech therapy are really helpful in facilitating a more complete recovery. And so before somebody's discharged, the patient will require assessment of these things in particular. So can you wean them from the ventilator, and can they protect their airway on their own? Can a patient swallow food without aspirating it? Or do they need a feeding tube or a gastrostomy? And can the patient participate in rehabilitation? These are really critical in determining what the care needs will be after the hospitalization. So where does rehab happen? Based on the outcome of these assessments, a patient can either go home with maybe outpatient rehab. They could require acute rehabilitation, subacute rehabilitation, or a long-term acute care facility. Typically, just in general, what these things mean are an acute care rehabilitation facility will require some degree of active participation in rehab, typically 3 hours a day for 5 to 7 days per week. And it's a combination of like physical, occupational, speech therapy, and it's customized to the patient's needs. Subacute rehab is a little bit less vigorous than acute rehab. It's typically 1 to 2 hours of therapy a day. And it's more based on like strength training and kind of functional ability. And then an LTAC, or a long-term acute care facility, is more intense kind of subspecialized treatment that's less focused on physical rehabilitation and can last like 20 to 30 days typically. And there are a lot of challenges to the rehabilitation period that extend even beyond the physical components of reconditioning yourself. There's short and long-term physical and neurologic deficits, and these things can include like fatigue, headache, concentration headache, vision deficits, short and long-term memory deficits, difficulties with articulation and speech, behavioral deficits or behavioral changes, loss of balance and coordination, and focal extremity weakness. And all of these things become way more evident in the outpatient setting than they do in the hospital, where really your primary goal is to just get over the initial rupture. And so what are some things that you can do? So you can break up your tasks into short activities so that you're not kind of overexerting yourself. You can keep a daily schedule of activities, write things down, try to link new information that you're receiving to old or more familiar information. Simplify explanations or conversations that you're having with people. Ask them for explanations of what they're referring to if you're having a hard time following. Take notes, repeat things to try to build your memory. Have a family or caregiver assist you throughout your kind of daily activities and allow you to do more and more as you go through them. Make sure you have a home base or a quiet space to rest. This is extremely important. Having something that's familiar or comfortable or quiet that's nearby that you can access to try to give yourself a rest at any point in the day is really critical. Keep a journal. I have a friend who did this when she had actually an ABM rupture, and this helped her tremendously. Just to keep track of things, but also to kind of document her own understanding of things. Show your feelings and concerns with a trusted loved one or caregiver. It's really important as a patient that you don't feel alone because it's just as much an emotional battle as it is a physical battle or a neurologic battle. So making sure that you kind of share your experience with somebody. It doesn't have to be everybody, but somebody that you can confide in to help you through this, because something that comes along with the emotional component of the stress of an aneurysm rupture is depression and anxiety. And so you need to have a network that can help you. And then keeping your mind active with stimulating things to help grow those neurologic synapses is also really important. So just some final comments here. Returning to work and school. These can be a really critical part of your identity, and it could be something that you really kind of yearn to get back to. But it's important to manage your expectations and the expectations of your employer or the school you're at. You might not necessarily be able to do all the things that you were capable of doing previously. And so kind of communicating with yourself and communicating with the person that you're going to be working with or working for is really important, so that you guys are all on the same page about where you're going to be in terms of your capabilities. And, also in part of like understanding your own ability at this point, is seeing a neuropsychiatrist or a neuropsychologist who can really assess your ability to do like more fine cognitive tasks, and they can kind of reveal these kind of underlying cognitive deficits that might make it more challenging for you, because it's going to be equally stressful for you to kind of uncover these things on your own. So having somebody help you with this can really lead to more success when you ultimately do return to work or school. And then never being afraid to ask for help. There's a lot of different resources for people who have ruptured aneurysms, and there's no better organization than the Brain Aneurysm Foundation for kind of supporting patients and their families and the caregivers with different resources to help them through it. This being one of them, but there's a bunch of different support groups out there in every state, or in most states. And so really, relying on these people to help you through it is there's no shame in that. It's very important to feel like you're not alone and that you have people to support you. So with that, I want to say thank you to everybody for being here, and thank you to Christine and the Brain Aneurysm Foundation, and open the floor to any questions that you guys might have.
Dr. Cooper, I just want to say thank you so much. That was fabulous. Lots of great information. So we had people submit questions prior and some online, but there's just a couple I wanted to touch upon.
Sure.
First, the thing that I see lacking so much is like the rehab piece, the resources for, because then again, people reach out to us, but in individual areas, the giving people the resources, and you mentioned social workers and like case managers, but it seems that across the board that kind of falls short, which is unfortunate. Seems like people go home and then they're like, what do we do? So it's hard, organizationally, we kind of always tell them to go back to where they were treated and, find these social workers or whatever. And then the other part semi-related to that is going back to work and school. Do you think, in your past experiences, do you think that doctors are honest with people when they send them home? Are they do they recommend the neuropsychologist or whatnot? Because that's just another thing that we find that's really hard, is that people do try and go back. But again, it seems like a lot of people are treated and then they're just sent home without kind of recognizing that whole body mind thing where people are different. They need time to recover. And like you said, the recovery journey is different for everybody. So I know like the standard answers are hard, but I think in terms of providing appropriate resources to families and patients when they leave, that these are things that I think maybe need to be addressed a little bit more. Again, across
I mean, you make a great point, right? I think about these things, especially like as I'm growing in my career as an attending, the different gaps that exist in bridging a patient from being, living their normal life to coming into the hospital, and then exiting the hospital and going to rehab or home. And there's a ton of them. I mean, there's a lot of standardized like reading that we'll give to patients or their families, but oftentimes these are lacking in, I don't want to say lacking, they're more emphatic on what it is that you had, and some of the things like I discussed earlier in my slideshow, like what is an aneurysm and how is it treated, with less emphasis on the aspects of like the emotional recovery, which is tremendous. I mean, I've attended talks on the emotional recovery from something like a brain tumor resection, and it's incredible. Like, the way that people judge things on the clinical side is like how well you can get up and walk around and move your arms and legs. But there's this whole other world of recovery that exists in the emotional and behavioral components of your daily life that could be changed forever, and sometimes overlooked. And so, pointing out that there are these things like neuropsychologists, that there are therapists that can help you with recovery from brain injury, and making those evident to patients and families is really important. And I also, to your second point about returning to work and school, I think as practitioners, we like to be encouraging and enthusiastic. with respect to kind of guiding the recovery. It's hard not to be, right? I mean,
Right.
you want your patient to be a success and feel like they're a success. Sometimes it can be challenging to be realistic. That being said, I think that I've often found the best responses to my conversations when I'm being a little bit more upfront about the hurdles that are in front of you. I think in the long term, it's helpful for a patient to understand that they might have some limitations, because if you tell them, hey, you should be able to go back to work in 2 weeks, for example, and then 2 weeks rolls around and they try and they fail, that can be very, emotionally disabling for somebody. And so kind of being open and thorough about the explanation of that is really helpful.
Okay, thanks. No, I appreciate that. And Lynn, you were going to ask some of the questions in the chat.
Yeah, we had quite a few in the chat. The first one is, what is the etiology of multiple aneurysms? Can high cholesterol lead to MMP9 protein modifying vessels?
Right.
It's a
So
tough one.
I guess the short answer for that is, so in patients that have multiple aneurysms, it can be due to a number of different factors. Hypercholesterolemia, or cholesterol, can certainly be a contributing factor to development of aneurysms, but things like high blood pressure, if they're going to cause an aneurysm in one blood vessel, can likely cause aneurysms in others. But along the same line, there is a lot of congenital or connective tissue disorders, or things like polycystic kidney disease, that can result in patients having aneurysms, not just in the brain, but all over the body. And it's in these types of things that you see multiple aneurysms develop also. So it's really a combination of factors. So things that are modifiable, like your blood pressure or your cholesterol, can certainly contribute, but also things that are out of your control, like congenital or hereditary illness, can almost more so be contributory to multiple aneurysms.
Okay. The next one kind of goes along. It says, what is the view on statins? Some research says high cholesterol actually reduces aneurysm rupture risk.
Yeah, so statins are helpful. I think that when I'm assessing somebody for an aneurysm, certainly if somebody has an aneurysm rupture or stroke risk factors, or high blood cholesterol, then I think that having them on a statin could be very helpful, and could potentially prevent an aneurysm from morphologically changing, although the jury's kind of out on that. But in my practice, the way that I will assess an aneurysm isn't necessarily influenced by whether or not somebody is taking a statin. For example, I won't put somebody on a statin with the hopes that I won't necessarily need to treat an aneurysm later. I still will evaluate them in the same way that I would evaluate any other aneurysm, at least right now. Whether it's through watchful waiting and kind of follow-up non-invasive imaging, or if it looks a certain way that I feel is concerning for potential rupture risk, then I'll still treat it regardless of the medical therapy that the patient is utilizing.
Okay. This next one is multiple choice. It says, which Joint Commission certified hospital is the best for treatment of SAH? Comprehensive Stroke Center, thrombectomy capable stroke center, primary stroke care center, or acute stroke ready hospital?
Yeah, that's a funny question. I guess if I had to pick one of those things, a comprehensive stroke center probably has the most resource availability, not just for taking care of ruptured aneurysms, but essentially all sorts of neuroscience related issues. But it's kind of a growing landscape. What I've noticed is that a lot of the hospitals that fall into one of those other categories are either building themselves or are associated with kind of a mothership hospital that is comprehensive. And so there's this wide network that kind of exists in most hospitals, where you find these resources kind of available elsewhere, even if it's within your network of hospitals. But if I had to pick one answer, I suppose that's kind of the answer that I would go with, because it's the most robust of the options that were presented.
Great. Thank you. Another one is, how many hours of CSF diversions must occur after SAH? Ideally 1 hour?
No. So CSF diversion is kind of a dynamic thing. It's funny, I had this conversation earlier today. When you put in an external ventricular drain for anything, but importantly for subarachnoid hemorrhage, the idea is that you are diverting cerebrospinal fluid with the idea of creating a more normal intracranial pressure environment. So you don't just drain off a ton of fluid. In fact, doing that could cause the aneurysm to rupture again if it's pre-treated. The idea is to recreate like a homeostasis type environment where the pressure in your head is more normal. And so oftentimes we leave drains in for days or even weeks to help manage the patient or get a better understanding of their neurologic status throughout their hospitalization, especially in that critical period of the first 2 weeks. We tend to not like to leave the drains in for longer than 2 weeks because they become an infection risk, but sometimes you have to swap out EVDs because the patient really needs them and you're still working to determine whether or not it can come out safely or if they need to be shunted, right? If you think about it fundamentally, a shunt is just a permanent EVD. So some patients require CSF diversion indefinitely.
Okay, thank you. Another one is preventative stent assistant coil better than emergency clipping coiling?
That depends. Effectively, I think the way that I look at that question is treating an aneurysm in a preventative manner better than having an aneurysm rupture? I think that if you can prevent an aneurysm rupture, that's always going to be the ideal scenario. But the important thing to keep in mind is that not every aneurysm needs to be treated. A lot of aneurysms are found incidentally. A lot of people harbor aneurysms that they would never otherwise know about unless they got some sort of cranial imaging for something else or they had a rupture event. And there's a tremendous amount of literature on trying to determine what factors about an aneurysm, whether it be size, morphology, risk factors in the patient or their family, that contribute to an aneurysm rupture. But as those things begin to accumulate in evaluating each individual patient's aneurysm, you can essentially say, okay, I find this aneurysm more likely to be at risk for rupturing. I think it should be treated up front. And some other aneurysms, like for example, a small 1 or 2 millimeter aneurysm in somebody who's otherwise healthy and doesn't have a lot of risk factors, doesn't necessarily need to be treated at all. It can just be watched.
Okay. Let's see, how to differentiate between ASAH versus ischemic stroke, clinical neurological signs kind of overlap.
Yeah, sure. Sometimes that can be very challenging, right? If you have the fortune of having a patient who's awake and alert saying that they're having this tragic headache, that can be a good clinical indicator of somebody having a subarachnoid hemorrhage. But sometimes patients aren't so fortunate and they have terribly altered mental status. Their exam is very suppressed, and that's where we end up relying on imaging to help guide us. The CAT scan is a very valuable tool, especially in the immediate period, to determine if something is a hemorrhage or a stroke, ischemic stroke.
Okay.
Okay. I'm going to hop in here since it's 6 o'clock, and there's just one more thing I want to ask that I saw in some of the questions that were pre-submitted is that people are asking, is someone more prone to ending up having Alzheimer's post-rupture?
So having Alzheimer's, not to my knowledge, but having longstanding cognitive issues, that can certainly happen. Depending on the location of the hemorrhage, the severity of their presenting exam, and kind of the way that their hospital course goes, all those things can be contributory to somebody having longstanding neurologic deficits, which can sometimes even mimic an Alzheimer's type presentation where they have short or long-term memory deficits, or difficulty recalling words or putting sentences together. That can seem like Alzheimer's, but to my knowledge, a link between the two specifically, I'm not so sure of.
Okay. All right. So, I mean, we could keep you here for probably 2 more hours. So, we like to stay to the hour time frame for everybody. But I want to just say thank you to you again for your time and sharing this great information with all of us. To everyone who attended, say thank you. Be sure to be following BAF on social media and emails, and sign up for emails if you haven't, as we're approaching our awareness month in September. And Dr. Cooper, any closing words from you?
Oh, no, I just wanted to say thank you so much for having me. Thank you to everybody for coming and listening. And man, I can't emphasize enough how great of a resource the Brain Aneurysm Foundation has been for me, for my patients, and really for everybody. So thank you. And you guys have my information. If you ever need to get a hold of me, feel free. I'm happy to answer questions if they weren't answered here tonight. So thank you, guys.
Excellent. All right. Thanks you, Dr. Cooper. Thanks, everyone. Have a great night.
Take care.
Bye.